So, welcome to the JPI-AMR webinar, AMR Research in a Post-Pandemic World. My name is Patrik Fagerstedt and I'm working at the JPI-AMR Secretariat at the Swedish Research Council. And the JPI-AMR, who is organizing this series of webinars, is a global organization of 28 countries supporting AMR research. We have a strategic research and innovation agenda on antimicrobial resistance, which consists of 6 priority areas: therapeutics, diagnostics, surveillance, transmission, the environment, and interventions. And we are also supported by the European Commission as a full non-voting member of the JPI-AMR. This series of webinars, this is the second webinar of today. We broadcast in order to highlight and clarify the importance of AMR research in the current COVID-19 pandemic. And in these webinars, we will have world-leading researchers and clinicians discuss the prevalence of bacterial co-infections, best practices, appropriate use of antibiotics, opportunities and challenges for AMR research in the context of this pandemic, but also of future viral pandemics.
Yeah, thank you very much, Patrick. And yeah, it's a pleasure to be here today. And I also would like to thank JPI-AMR to kick off with for arranging this and the preceding webinar on a very topical aspect of AMR in the conjunction with COVID-19. And as we can see, we have a lot of registrations today, which confirms the interest and underpins the importance of this topic. So, so I'm very happy to moderate today's session. We will have a short introduction presentation by one of our panelists, and then we have basically an open discussion. As Patrick said, it would be very good if you could, or if you have a question, please do submit it through the chat function, and we will try our best to address those as they come in. Okay, so please let me start with introducing our panelists. So Raphael Cantone, he is head of the clinical microbiology department at the University of Ramon y Cajal in Madrid, and he's also a professor of microbiology at the Complutense University in Madrid. We have Adam Roberts, who is a reader in antimicrobial chemotherapy and resistance at Liverpool School of Tropical Medicine, and also a very active researcher in JPI-AMR. We have Birgitta Henriques Normark in Sweden, and she's a professor in medical microbiology and pathogenesis at the Karolinska Institute, and as well as a medical doctor. And as we continue, we have Neil Clancy. He's the chief of infectious diseases in Pittsburgh healthcare system and the director of mycology research unit at the XDR pathogen lab at the University of Pittsburgh. And we further have George Herringhuizen, who is the Chief Legal Officer at the Center for Infectious Diseases at the Dutch Public Health Institute in the Netherlands. And Benedict Huttner, who is attending physician at the Infectious Diseases Department at the University Hospital in Geneva, and is representing WHO, or is speaking from perspective of WHO today. And then finally, not on the list, but in our, it's basically our, or maybe our surprise guest. Most of you will know Herman Goossens, who is a professor for medical microbiology at the University of Antwerp and well-known researcher and active in the field of AMR. And so we are very happy to have him on the panel today. So without further ado, you also have the introductions on the panel list on the website. If you want to come back, I would like then to move on to the introduction presentation. If we could, and I would like to hand over to Raphael then to give his presentation.
Thank you very much, Steele, and thank you very much, Patrick. I'm just going to do a very brief presentation regarding the COVID, the SARS-CoV-2, and also resistance, you know that we have been taking care of these patients, but these patients are infected by the SARS-CoV-2, but these patients are admitted in the hospital. So we have concerns about this situation, and there has been some publication alerting that this patient has infection as other patients that are admitted in the hospital, but one of the first figures is that this patient has more infections than a normal patient that is admitted in the hospital. And we have been comparing this with patients with flu. If they were super infected with some pathogens, for instance, Streptococcus pneumoniae, or even Staphylococcus aureus, methicillin resistant, there are some publications just trying to answer the questions. We know that this patient has bacteremia, are frequently urinary tract infection, and this infection appear in most of the patients that are terminal patients. Also, we know for the series that has been published that this patient, there is a lot of use of antibiotics, but also antifungals, and we don't know really yet which is the impact on antimicrobial resistant development. So in the next slide, you have some bullet points. Can you pass the next slide, please, Patrick? Yes, here you have some bullets of some, let's say, some ideas that I take for some publication. Another ones came from my personal overview. Some reason why this may have less resistance in the microorganisms than we can isolate them if this exists. And this can be related to the personal hygiene, the hygiene procedure that has been implemented all over the world or reinforced, the use of personal protective equipment, obviously also the social distance, but even in patients management, you know, less time or less times that the patient are attended when they are admitted in the hospital, the early antibiotic use, and also in the outsides of the hospital, there are some ideas telling that there was potential less antibiotic consumption in outpatients because there was a reduced access to pharmacy. We don't know yet. We have to see what is going to be published in the future. But in the next slide, you can see as opposite list that you can see here some ideas that say the contrary, that COVID and infection may have a major impact on antimicrobial resistance, because there are patients that are admitted in the hospital. Some of them has a length of stay that is very long compared to another patients. There has been an overcrowding of healthcare system. Even you have a ward like we have patients years ago, no one patient in a room or two patients per room. We have wards with a lot of patients, even 20 or even more. You can see the pictures on the internet. Also, there has been a relaxing of measures preventing the spread of multi-drug resistant microorganisms. In the institution, we have to take care of the patients, the situation, the respiratory infections, or for the COVID, and there has been a decrease of the screening culture of these multi-drug resistant microorganisms. So we don't have really a picture in most of the cases, which has been the situations. And also, another question that is really there has been an increase of the empiric use of broad spectrum antimicrobials, and even in some of the treatment it was included an antimicrobial, the azithromycin plus hydroxyquinolone, and we don't know yet which has going to be the impact of this wide use of the azithromycin. Also has been expert support of the use of antimicrobial agents, because this expert was doing taking care of the patient but not taking care about the stewardship programs. Also the increase of telemedicine, that relation with the patient was totally different. So this may have also impact in the use of the antimicrobial agents. And regarding the laboratory, even there has been a decrease in the laboratory capacity on antimicrobial resistance, because the laboratory was focuses in the diagnosis of the COVID-19, and also the absence of use of diagnostic tests for detecting these antimicrobial resistant microorganisms, because the laboratory was also taking care for the COVID and not for the other things that normally we do in the laboratory. So these are some ideas that I think we can discuss later, and that was my presentation as an introduction. Thank you very much.
Thank you very much, Raphael, for the very comprehensive short introduction into the topic. I would like to come, or first remind everyone who has joined, there is a possibility that you can submit your questions through the chat function. If you would like to do that, we are trying to address as many as possible within the time frame. Maybe to kick off the discussion after Raphael's introduction, I would like to put to the panel your views on what do you think the impact are. Maybe if we start with antimicrobial use, which is obviously something which is linked to the COVID-19 pandemic. Do you think there will, what will be the impact of increased interventions with regards to AMR in the COVID context? I'm putting this out, and if you want to raise your hand, I can pick you. Herman, you want to start?
Yeah, thank you very much, Till. Sure. So I think that's going to be very difficult, and I think certainly in hospitals we see a massive use of antibiotics, as explained by Raphael, antibiotics, but also antifungals. But on the other hand, in the community, we see a huge reduction of antibiotic prescribing. And actually, I saw some data yesterday from Belgium, and I heard some similar figures in other countries in the world. In my country, we have a reduction of the first 4 months of 2020 of antibiotic use in the community by 50 to 60 or even 70% for a number of reasons. And so this is a massive intervention in terms of reduction of selective pressure. So it'll be very interesting to see what happens in the community as opposed to what has happened or what is happening in hospitals. That's just the first brief comment I would like to make.
Thank you, Herman. Birgitta.
Yes, I wanted to say actually on the same line as Herman was saying, and we also see in Sweden that we have a reduction in prescription of antibiotics specifically for respiratory tract infections, and we also see that we have fewer respiratory tract infections such as, of course, meaning that we get less prescriptions of antibiotics. So I think this is really important, that I think we see one thing at the hospitals and one thing in the community, and one is actually more decreasing the use of antibiotics, and maybe the other one is actually increasing the use of antibiotics, meaning that we might get more antimicrobial resistance of multi-drug resistant bacteria in the in the hospital setting, while we might see less in the community. So this is something we have to see combined. What will be the results in the end regarding resistance?
Okay, thank you, Birgitta. Neil.
Yeah, I would say, at least in the States, the hospital experience is quite variable. And certainly in our hospital, outside of an early phase epicenter in the US, our in-hospital use is down 40% as well. So it's not only an outpatient phenomenon. With that, however, within the 2 specific units on the medical floor and the ICU that we devoted to COVID care, on those floors, antibiotic use is up. And I think what you're going to find is this is going to be a hyper-local story where there's going to be differences, even within a city from hospital to hospital and within units of a hospital. And we're probably going to have to break this down to really understand what's happening with the microbiology and with the AMR as the story unfolds. I'll also say, I think the outpatient story, the big thing, of course, is going to be the fall and influenza season, and what happens with outpatient use. Certainly in the States, there's an awful lot of inappropriate antibiotic use every flu season, and this could be compounded with COVID and flu coming together.
Adam?
Thanks, Till. I also think, sort of building on Neil's comment there, when individuals feel that they can go and seek healthcare as normal, there may be an upsurge in the numbers of antibiotic prescriptions actually issued. It'll be very interesting to see in the short term if there's a little bit of a bounce.
Benedict, do you want to respond to that?
Yeah. I just wanted also to mention, I obviously can't talk for WHO. I'm just a consultant, right? So what I say is not the opinion necessarily of WHO, but I think
yeah, of course.
It depends also. I mean, with regard to AMR, I think what we most care about is multi-drug resistant organisms, and they're really in the ICU. I fear that the antibiotic use density massively increased also in the medical wards, even though the total consumption in the hospitals may go down. If you look at the percentage of patients exposed to antibiotics and how long of their stay, how many days they receive antibiotics, my impression, at least here from Geneva, is that this went massively up, and I kind of fear that combined with a high workload and the use of gloves, we may see then an increase in AMR, but obviously this may very much depend on the different settings and the specificities of each country.
May I expand from this as a question? So obviously, from what you just described, there is a huge impact of the change of provision of medical care and also seeking medical care. And that is certainly something which is in high-income countries is very important. If you think about the low and medium-income countries, what I could imagine is that there is an impact on access to medical care, which is even worse with under the lockdown situation. So it may be altogether in every country also have an influence on the over-the-counter access to antibiotics. Do you have any views on that, or on any observations that, let's say, inappropriate use in terms of over-the-counter use has increased or might increase? Adam?
I think
so there's no observations I'm aware of yet, but it is known that fear can actually drive the increase in over-the-counter sales of antibiotics. Quite a lot of people in around the world will think that anything to take for a viral outbreak is better than nothing.
Yeah, we made that observation that choice of treatments or recommendations of treatments have been spread across the globe. Herman, did you want to say something on this?
No, I haven't seen any data on this. Just one other comment I would like to make about the massive reduction of antibiotic use in the community. It would be great to see if this has any adverse effects, because if we can massively reduce antibiotic prescribing in the community, for instance, in my country where antibiotic use is still fairly high, that could be a good argument for in the future to say that, even if you reduce antibiotic prescribing, you don't see any adverse effects. And so I think that's another interesting observation, perhaps because of this massive reduction of antibiotic use that we should be aware of.
Well, the only thing is, Herman, but this is probably a speculation or a discussion. People, at least in my country, in Spain, there was a strict lockdown. So I think this can also influence in the transmission of respiratory tract pathogens. So we don't know. I'm very curious to see that. And also I'm very curious to see which is the difference in the different countries according to the resistant rates. Probably the impact could be different in Spain and in other countries, in North European countries, that they have less resistant rates, or even in another countries that has even higher resistant rates than in Spain. So I'm very, very curious on that.
Yeah.
I think, George, you had your hand up. Did you want to say something? You didn't have a chance yet? No? Brigitta?
No, I just wanted to say that I looked a little bit into the data for the public health agents in Sweden. And the tendency is that we get less reporting of MRSA, for example, ESBL and VRE. So there is a tendency, at least. Let's see what happens in the end.
And for sure, from my perspective, the jpiamr, again, as an organization or a tool, will help bringing those perspectives together. So I see there certainly is the right forum to discuss these different country-specific aspects in this situation. Neil, you wanted to?
Just as a quick follow-up to Herman's point, I do think this is a real opportunity, because with these reductions in antibiotic use, it gives us a chance, I think, to understand, if we understand what the outcomes in these patients are, where are we overusing the antibiotics, and can we use this as a moment from a stewardship perspective to do a better job in restricting the marginal or inappropriate use that we have. Certainly in our healthcare system, I take care of a lot of veterans. There's a lot of skin and soft tissue, chronic infections. Those patients have just stopped coming to hospital. And a lot of them actually don't have cellulitis or infections. They have vascular disease, they have lymphatic disease. And I think this is an opportunity for us to maybe learn about where we're particularly egregious in overusing antibiotics.
Yeah.
Herman, you wanted to respond specifically?
Yeah, briefly. I would like to respond to Raphael, to Brigitte. So Raphael, in the past, when you looked at antibiotic consumption in the community, incidence of respiratory tract infection, they were exactly the same curves. I don't think we'll see the same phenomenon. And so I'm not so sure that lockdown alone can explain the reduction of antibiotic use. I think there's probably other reasons for that. And again, that will be interesting to look indeed at outcome of this massive reduction of antibiotic use, and that could be used as an argument to convince countries to reduce antibiotic prescribing. And then coming back to what Brigitte was saying, in my hospital for 3 months we did not see any more MRSA, but now the last 4 weeks or so we see more cases. So hand hygiene and the protective equipment, they certainly have had an impact on, for instance, MRSA infections in hospitals. But the question is, how sustainable is that? And that I'm not sure about. Not so sure about.
But I think one problem in the hospital, Herman, and at the very beginning, we have this situation that surveillance studies just for the culture, the normal culture, nasal, rectal culture, were not done in the hospital because all the doctors, all the care to the patient was focused in the COVID, but not on search on antimicrobial resistance. We are trying to see that in our institution, but I'm sure in another institution we'll have the same data very soon published. And I'm curious also to see that if this is, well, the reduction, for instance, that you mentioned, Herman, is because in your institution you didn't search for this microorganism.
Brigitte?
Yes, may I just say also that we looked into pneumococcal, invasive pneumococcal disease, and we can see that there's a reduction really in the number of cases, not only in Sweden, actually in the whole of Europe. So we've even formed a new network to actually try to understand why what is the reason why we see this. But it suggests that maybe the management of how we treat, I mean, this COVID-19 with the restrictions for travels and lockdown, etc., can have had some effect. But it's of course difficult to say, as you were saying. But I suppose that if you have an invasive pneumococcal disease, you would come to the hospital, that you would really go there. But so maybe it's actually really a reason why we see this decrease. I don't know.
So maybe if we what we just discussed now, I think is really, maybe in the first place, an unexpected discussion point where we said there's a reduction of antibiotic use in the community. I think this is really important to consider, and as it was said, a lot of opportunities arise from that. And then also the surveillance impact or the finding of AMR in the hospital setting, which is impact due to the different or the procedural implications, let's say. Can we for a moment speak a bit about the increased use of antibiotics in direct correlation with COVID-19 patients? Do you have any observations there, how the impact of, well, on the obviously antibiotic use, but also potentially resistance, which you observe in pneumonia isolates or similar? Anyone wants to go first? Herman?
Yeah, I have no data, and I think it's probably too early to look at those data. But to follow up on your question, Till, and maybe a question then to Brigitte, because you're a pneumococcal expert. Do you think that this massive reduction of antibiotic use will have an impact on resistance, or you think that's too short and may not be sustainable in terms of selection of resistance?
I think it might have an influence. I mean, at least in the hospitals, if you're treating, because they are treating it empirically today. We don't know, I mean, what bacteria they're treating, or maybe not even the resistances. So of course, if you're really using these broad antibiotics, and if you're doing it, a lot of it, I mean, in China, they have done it, what I understand, to a very high percentage among the severely ill patients. What I mean is, of course, that can lead to a selection. But as we see in Sweden, I mean, we have pretty low, we see that the prescription rates in the community has really gone down. So that might, on the other hand, maybe been beneficial for not spreading the antimicrobial resistance. So I think there are two coins of this.
Yeah, but for pneumococci, do you think for pneumococci we might see a drop of resistance in several countries in the world?
That's hard to say, but what we see now is that we see very few cases if you compare with before. So that's what I mean. I don't say anything about resistance rates, but regarding the invasive cases, they have really gone down, and we don't know the reasons for that. Maybe it's because the grandparents don't meet their grandchildren. We don't know, and that that you don't don't have all these restrictions. So maybe that influences this. But this is what this network is going to try to find out. Because it's not only Sweden, this is the whole, many countries in Europe.
Benedict, you want to respond?
Yeah, I just, there may be also long-term effect with regard to the coverage. There have been several reports now that in many countries, vaccination coverage, childhood vaccination went down. So, there may be a long-term impact of that. But I think if you talk about antibiotic resistance, we really have to differentiate the different bacteria, right? The multi-drug resistant nosocomial pathogens from the community pathogens. I think we're going to see potentially very different trends. And also depending on the setting, I think in a setting where you already had a lot of carbapenemase producing Enterobacteriaceae, and I'm very curious to see, for example, in Italy, what will happen or what happened in the ICUs where the prevalence was already very high.
This is a very good. Thank you very much, Benedict. This is a good introduction into our next section, which I would like to discuss, is around knowledge gaps. So we all said now it would be good to see, and we have to investigate this and that area. Maybe could we focus a bit on where you see the biggest knowledge gaps in the current scenario, which we have, and then likewise where we would like to put our research activities on, in which areas. Again, Birgitta, you want to go first?
I can just start. I think we really need more data on super infections. The bacterial infections. I think that they haven't taken enough samples. We have to do more and do more sequencing, look into resistance patterns, these kind of things, so that we really know what we are treating. And that might also mean that we can have another way of treating these severely ill patients as well. Now everything is done empirically. So I think we really need to collect more data here.
Yes. Neil.
Yeah, I'll agree with Birgitta. Just basic epi and incidence and basic microbiology is really been lacking. I'll also say, to return to a point earlier, I think we're really going to have to make an effort to go and find these bugs and do some surveillance. And I agree with the point that the amount of micro that we're doing just in routine management of patients is way down because of the infection prevention aspect of this disease. So I think systematic surveillance and these type of programs are going to be very, very important.
I would agree with that. Benedict?
Just based on the studies that have been published so far, something I noticed is that very often we talk about super infections as if it was a homogeneous group. I think we really need studies that better differentiate with the patient who has COVID, who is hospitalized. Is there a co-infection or not? How do you distinguish potential bacterial pneumonia from only SARS-CoV? Or with patients who are in the ICU and who then have nosocomial infections, because it's something completely different, also with regard to preventability. Because obviously, yes, you will have healthcare-associated infections, but the strategies for prevention and the implications for stewardship are completely different.
See two hands. Neil, you want to respond directly, and then Herman?
I just wanted to make one point that I forgot to bring up is I think really a focus for the microbiology should be the autopsy studies, which there are several hundred autopsies that are published nowadays, and there's really no micro data. Reading those studies, it would suggest maybe a quarter of patients in ICUs dying have histopathologic evidence that's consistent with bacterial pneumonia. However, without the micro, it's impossible to interpret those data. And maybe going back to some of these European centers have done a fantastic job in getting autopsies. If we could go back and try to, with PCR or other methods, figure out, are there bugs around and what's really happening?
Herman, you want to follow up? I saw
it was, that was exactly the comment I wanted to make as well, Neil. So thank you for that. Yeah, I agree with you. And I think what we desperately need is more information on the role of bacterial secondary infections. We know that an H1N1 pandemic was between 12 and 19%, with seasonal flu it's around 25%. But the question is, as Benedict said, did they die of or did they die with bacterial infections? And I agree with Neil that autopsy and lung tissues should be able to give us that answer. And I've reached out to several hospitals in Europe where they have done autopsies and where they've investigated lung tissues, and I'm trying to collect some data retrospectively with a simple protocol. But from what I hear so far, the lung tissues that they have looked at, they rarely saw bacterial secondary infections. So I don't know to what extent that is, if that can be confirmed, that bacteria do not play an important role. I think it's far too early to say that, but this kind of information should be rather easy to collect because a lot of hospitals have collected lung tissues, have looked at bacterial infections, and so that's something we really desperately need, because that will have a huge impact if we have a next wave on the recommendation of whether or not we should use antibiotics more aggressively, more early during the course of the disease.
Yes,
Adam, or Raphael, go ahead.
No, I was going to tell that I totally agree that we need this data, Herman, but it's going to be very, very difficult to collect. Even in Spain, I can say that at the very beginning, the autopsies was forbidden because of, let's say, was the risk of infection to the people doing this, the doctors and technicians doing these autopsies. And then we start to do that. In our hospital, we have a series. We have done no more than 12 autopsies up on top of the patients that died in the hospital. We have at the same time even 1,000 of patients in the hospital with COVID. So you can imagine that. And there was no time to do this procedure, but at least I think this will be very, very important. I totally agree, Herman. And if you can centralize this data, I will appreciate that.
Can I just add to this before Adam wants to take the floor? So that's exactly a good example of where we should collaborate in Europe, because every center will have a very limited number of autopsies. In my hospital, we have, I think, around 20 maximum. I had reached out to centers in Amsterdam and in Berlin. It's the same low numbers because of those reasons, Raphael. But that's exactly where we need collaboration, and with a simple protocol, collect this information. I think if we have larger numbers, we should be able to conclude on the role of bacteria in these patients. Sorry to interrupt you, Alan.
So, thank you. I think there's also a need to consider what happens outside of the hospital environment. Hospital, we've got these hotspots of antimicrobial usage, but the residues, etc., are going to translate into an environmental increase in the drivers of resistance. And I think it's very important to fill that knowledge gap as early as we can in using surveillance systems which can really sort of drill down into the fine scale detail of resistance in the environment. If we use national scale levels of antimicrobial resistance data, we're probably going to miss locally geographical hotspots, which are primarily due to the clinical use of antibiotics within this particular pandemic.
Okay, so that's the looking at the well, obviously that's true. That's very true. So the environmental aspect, I think, is something which we of course need to focus on with regards to AMR and antibiotic residues and distribution of those and the impact on of them, and then as a impact from the COVID-19 pandemic that will certainly play a role. Can I quickly come back to the hospital? Sorry, Adam, because it was said, and I think Birgitta, you said that everything is treated empirically. We are lacking autopsies. We don't understand the role of the bacteria in this. Really, we need to have more data. I would like to come to maybe it's also, of course, it's a knowledge gap, but it's also a technology gap. Is the role of diagnostics in this field? It seems to me that there is, in the wake of the urgency of the situation, of course, the tendency to, or the willingness to have an empiric treatment is there. But certainly, it would be much better if we could make more informed decisions and had some support tools there in the form of diagnostics in the hospital. Could we have a bit of a conversation about this in terms of how you see the current situation, and if there are any specific gaps or where evident gaps which have been there before, or where gaps which have been before became more evident now, and the lack of available diagnostics is more important in this current situation, or maybe not? Any comments on this?
Yeah.
Herman, I see you.
Yeah, well, I think diagnostics, of course, are very important, but I think they might be particularly important in the future because we might be using drugs that might be causing more bacterial infections. For instance, we're going to perhaps use tocilizumab or other drugs that may interfere with the interleukin-1 receptors. We might be using a lot more corticosteroids because of the recent fantastic data coming out of the recovery trial in the United Kingdom. And so if we're going to use those drugs more intensively, more massively, more frequently in these COVID-19 patients, that may increase the risk of bacterial infections. And so therefore, I think it's going to be very important to have diagnostics to document indeed bacterial infections and to treat early on with antibiotics in these patients, particularly treated with those kind of drugs.
Birgitta, a comment on pneumococcal?
Yeah, I think also it's very important that you do a rapid diagnostic so that we don't wait, because the problem is here that you put in the antibiotics and then you take the sample and then you might not get the response. I mean, know what you're actually treating. So I think we have to really see that we get an earlier diagnostic than what we have today as well. And so that somebody said, and also to really look into when the patients come into the hospital, not only when they are at the ICU unit, we need to know what is happening before that too.
And that is something you mean specifically for bacterial infection, or as a whole, obviously?
I mean, we need it for fungi as well, I suppose.
Yeah, of course.
There's a lot of fungi treatment that is being done as well. So I think that's important.
Benedict, I see your hand.
Yeah, I think there's still many practical problems. I think, we have to differentiate the ICU population, where it's relatively easy then to have lower respiratory tract samples. But the vast majority of patients that are hospitalized will not end up in the ICU. Nobody will want to perform a bronchoalveolar lavage with risk of deterioration. And already, in routine community-acquired pneumonia, even with our in studies that use all the available diagnostics, we have a diagnosis in the minority of cases. So I don't know what the solution is. Definitely, we can sample better, but even if you talk about sputum samples, we know that in elderly patients, most of the time you can just forget it. You will not get a high-quality sputum. So I agree there should be more systematic sampling, but I'm still kind of worried that in most patients we won't end up this much.
Okay.
May I just respond to this?
Yes, please. Yes.
I mean, I agree with you that is a problem with how you take the samples. But usually, I mean, elderly people they are not so colonized. I mean, in the nasopharynx either. So it might be that even you can take a nasopharyngeal samples if you cannot make a real sputum. Of course, sputum or a ball is the best one. But I think there are other ways of doing it as well. At least you know what you are dealing with.
Thank you, Neil. I saw you had a comment.
Yeah, I think a lot of it comes down to planning, and it involves multiple people with the planning. I think you have to have protocols in place for who you're going to test and how you're going to test. I think it has to be integrated into your stewardship program and what you're going to do with results. One thing we found very useful, though, was having dedicated teams to the collecting of samples, and this allayed a lot of anxiety on staff's behalf about collecting samples in these patients and risk of infection. And it also, I think, resulted in higher quality samples being collected. So I think now that we're through sort of the worst of the first wave, certainly in Europe, more so than the States, planning these things out and getting all the constituencies on board is something that should be feasible before the flu season hits.
Okay, so maybe could we maybe revisit or one aspect of this is of course data sharing, and I wonder if George would like to comment on data sharing, maybe for what we have just discussed and the opportunities coming from this, or the knowledge addressed from this, but also in terms of the autopsy suggestions which have been made. George.
Thank you. Well, actually, I don't think that there are really major problems in data sharing, as long as you see to it that patients are protected in their privacy. So, and normally speaking, I speak especially from the European situation. I know that as long as your national legislation permits, then you can also cross-border share your data, as long as you have good protocols and see to it that patient data are not recognizable. So you have to do some pseudonymization or anonymization in a decent way. But the most important thing to put people at ease and institutions at ease is that you have a decent protocol where everybody works together in the same way and you gather the data in the same way. This is, of course, technically speaking, an imperative, but also from the legal part of it.
Of course. And as the situation progresses, well, at least from my perspective, there was an interesting observation. In the beginning, everyone was chasing the few samples which were around to get access to samples for research and development, for diagnostics or other studies. And all of a sudden, everyone had their own samples. But as we move on, as we just discussed on this occasion, or on this example with the autopsies, there will be an increased need for collaboration, and also that may mean that we need to revisit or use the existing or future structures to make samples available. I wonder if anyone wants to comment on this with regards to how the current situation or future situations may help or not help, which need to be, so if they help, if there are gaps which you see, is there anything which needs to be addressed in the COVID and AMR specific situation? All samples available?
What?
That seems to be a difficult question, or it's not a question because it's already resolved. Brigitta, you want to?
Yeah, I can just say that in Sweden at Karolinska, they are putting up a biobank now, really consecutively taking into samples that are supposed to be a research asset in the end, so that people can use this for research. And I suppose I don't know if it's being done on other places, but I think this is a really great effort.
Herman?
Yeah, I think the amount of samples that have been collected in Europe over the last 4 months must be massive. If I look at my own hospital, if I look at the hospitals in Belgium, I mean, everybody became a COVID-19 researcher, and everybody has his or her protocol, and everybody started collecting samples. So I think the biobanks must be full of the thousands of samples, whether we have access to them or whether we can use them for collaborative research, I'm not so sure about. But it's too bad that we didn't think about, for instance, setting up a protocol for collecting information on autopsies and lung biopsies. I think that would have been something we should have been thinking of. And I think we would have had the answer already by now. If we thought about it from the very beginning, the role of bacterial secondary infections, that would have been a good opportunity for collaboration.
Okay, very good. That is, that's again an interesting or an important aspect, and it addresses also the, let's say, the difficulty in accessing or having the knowledge in the first place, and then as it is generated, accessing the knowledge across the board. And as you just said, Herman, so many samples have been collected. Everyone became a COVID-19 researcher across the world, and a lot of knowledge has been generated and published. And as we all experience, this is increasingly difficult to identify the relevant literature and the relevant publications, especially if you think about AMR. And I wonder, for example, Adam, I know you have had some activity there. If you want to mention something, how these things may be addressed with an AMR specific head-on.
In terms of the literature, do you mean, Till?
or in terms of the access to information and filtering information, making information available in order to drive the field forward?
So I think there are different drivers which will drive this field forward. So the pandemic represents an exceptional opportunity for many academic and clinical academic careers. So people are, to my knowledge, are quite precious of the samples and the data they have until they're in a position at least to go onto a preprint server. I don't know if that's the same situation that has been seen with my clinical colleagues on the panel. Yeah, so what we have seen, one of the things that me and some colleagues at Liverpool School of Tropical Medicine are doing is collating all of the relevant literature that we can find on secondary bacterial infections, COVID and AMR. And there's a huge uptick in the output now, to the point where it's difficult for us to keep up with the numbers of manuscripts and opinion pieces coming out on the topic. So we're definitely in the exponential phase of data publication.
Benedict? Oh,
yeah, I was muted. Sorry. Yeah, I just want to make a general comment. I think what we saw during this COVID pandemic is maybe also how our whole research system is broken. Because I think clearly this fact that everybody wants to keep their own data, has to get their own publications, everybody was not helpful, at least for the first wave of the pandemic. We could have maybe done a better job, and I think the problems are inherent. There is no easy fix, but for me it was really quite striking how broken the system is.
Any further comments on this? Neil?
Yeah, I'll just say I think part of it was exacerbated by the fact that early on, the quality of the data that were reported were really very poor. And I don't know that the infectious diseases and microbiology community were really part of the early reports. But to the extent the culture data were reported early on, they were just that, culture data. There was no clinical context, there were no case definitions. I think something those of us in infectious disease and microbiology going forward should do with our colleagues in other disciplines who are looking at this is make sure that we do a better job on defining disease, defining colonization, explaining what we're doing with the micro, and get data out there that are a bit more interpretable. And I think, as Adam says, we're just beginning to see that now. But I think it's created some degree of confusion and uncertainty with what's been published up to this point.
I agree with that, Neil. I think there will be a lot of data published where simple detection by PCR of other bacteria from COVID samples will lead to publications saying that there's a higher number of bacterial secondary infections present.
Yeah, and maybe something we can do as a community is, as those data appear, make commentary on them and try to put them into context. And I think we're beginning, Adam, to see the first now molecular, there's a film array preprint that's out there from the UK. So these data are beginning to emerge, and you're going to double the number of pathogens that you're detecting from what were generated with the culture data.
Yeah.
So even if we're not involved in these studies, I think we can offer perspective and commentary and try to put them in appropriate context.
I think the key will be to have the non-COVID control samples in the studies. So it's the background colonization, or at least presence of the various other bacteria, can be quantified accurately.
So
Herman?
Yeah, so I think it is important to develop protocols if we have a next wave, that we have these protocols available to study the role of bacteria, to study the role of colonization versus infection. And I don't think we've done that good enough, maybe because we focused a lot, understandably, on the virus. Maybe it was driven mainly by virologists, and I also suddenly became a virologist, although I kept on saying that I'm not a virologist, but then suddenly I was a virologist. So there was a lot of focus indeed on the virus, but I think we shouldn't forget that there are also bacteria. And maybe if there's a second wave, we should think about developing protocols where we specifically look at the role of bacterial infection, bacterial secondary infections, and do the necessary microbiological sampling and diagnostic testing to unravel the role of bacteria in these COVID-19 patients.
Maybe to follow on from that, do you see specific opportunities arising from jpiamr and maybe the digital interaction, the VRI, and which enables us? I mean, we're all now used to interact virtually, but those things have been there set before, and now it looks to me that there are from us being all in these networks enables us to respond to those pandemics or those situations more rapidly. Maybe, yeah, so concretely, do you see a digital aspect to this preparedness, to finding the same protocols, exchanging data? Would be interested to hear your view on the opportunities which come from the connectivity which we have achieved.
I think JPR AMR would be a fantastic and a perfect infrastructure or let's say structure to organize these kind of studies through digital platforms or any other kind of platform. But I think JPR AMR would be well placed to do these kind of studies, to plan these kind of studies, to organize these kind of studies. Absolutely.
Any further views on this?
Yeah, if I could just make one. So, you know, researchers will follow the money. So if the JPIM launch a specific call on the background of COVID and AMR, it will be followed by the researchers. So there is almost a responsibility for the JPIMR to frame the next questions really, really well.
That's what we're here for. Benedict, thank you.
I just have a comment about the types of studies, because we talked about surveillance studies, but I think ultimately the only type of study that will convince physicians not to prescribe antibiotics is an intervention study where you randomize patients to either receive antibiotics or not based on pre-specified criteria and showing that there is no worse outcome. Because we can do as many surveillance studies as we want, I think this will not necessarily change behavior.
Behavior change, of course, is a key point which you just mentioned, Benedict. That behavior change and change of procedures are heavily impacted by COVID, and those certainly, as we have now mentioned quite a bit throughout this conversation, is that we have will have impact on the consumption and the development of AMR. I'm just having a quick look at the, we are coming to an end of our discussion. We could continue easily but I would like to just to respond to the audience again and see whether they have any questions. I see there's the question on biobanks have come up. If there are any links of COVID-19 related specific biobanks in Europe, which could be shared. Does the panel have any sight of anything specific biobanks which can be accessed by researchers? George?
You have, of course, the European Virus Archive, which is a Horizon 2020 project of the European Commission, where you find a massive amount of COVID-19 materials and their derivatives.
Thank you, George. Any other comment on COVID-19 specific biobanks? If it's not the case, then there was a question on LMICs. We touched them a bit with the over-the-counter drugs, but from a different perspective, maybe do the panelists have any specific views on AMR challenges post-COVID-19 and LMICs?
Wow.
So sorry, go ahead, Herman.
Go ahead, Adam. No, go ahead, please.
So I was just going to sort of state that there is so much unknown about the drivers of AMR in different geographical regions in different LMICs that it's going to be really difficult, if not impossible, to predict a blanket theoretical response to the epidemic in terms of AMR. And I think it really does make the case for increased surveillance at local and national levels.
Herman?
Yeah, just exactly, I was going to make that point as well to follow up on this. There's very little data available. As you know, we have the Global Point Prevalence Survey, where we collect data on antibiotic use and resistance in hospitals in low middle income countries, but all of that has stopped. We've adapted the protocol to collect detailed analysis on COVID-19 patients, but people just don't have the time to fill in the forms to collect the information. So understandably, they have other priorities, and there's, I think, very little data available, unfortunately, at least for the moment.
Yeah, and I would agree with both of you that the it's a very complex scenario in LMICs, as we have discussed as we started this meeting, that there is a reduction of antibiotic use in the community, which we wouldn't have expected at the beginning of all of this. Likewise, we will see similar scenarios in LMICs in different settings, but it dependent on lockdown rules. This has, of course, a tremendous impact. We see this in some of our project partners in LMICs, where, for example, in agriculture, the activities can't continue. Hence, you don't have exposure, you don't have consumption. So that will all have an impact, and it will be interesting to review. Unfortunately, we are coming to the end of our meeting. If you would like to say a final statement about the AMR situation in the connection with COVID-19, please raise your hand now. If that is not happening, I'm just giving you a few moments. Oh yeah, here goes Adam.
I think kind of a final consideration from me is that any surveillance implementation needs to have a longevity which will allow for the selective landscape to change due to COVID and differences in antibiotic use, and then also the trickle of any selected genes from commensals into pathogens. So there needs to be a requisite time period with which any resulting surveillance is undertaken.
I absolutely agree. We need to see that, and we need, as with all interventions, to see that AMR, there's a change to AMR. This will take time, and that's usually very difficult to get in funding streams or schemes. Yeah, I would agree with that as a long-term aspect. Neil, you want to comment or say something else?
Yeah, just very quickly, and I'll have to be careful how I word this, but I also think this is an opportunity for the AMR field. There's certainly in the States unprecedented awareness now of infectious diseases and the need to be prepared for unexpected infectious diseases challenges. And I think it's an opportunity for us to educate the general public about AMR and to dovetail it with what's going on in COVID. So I think there's opportunities on the research front and also on the public education front that we should try to make advantage of.
Absolutely. Thank you very much, Nia. This was a perfect final statement, and I would second that. The extent to which the general public has picked up terminology and the aspects of infectious diseases is incredible in this scenario. So the number of times we hear testing, and viruses and bacteria and AMR is really increasing. This is a positive aspect, and that we will see certainly some impact of that. What that will be content of or subject of our research, and on top of the biomedical research and all the adjacent fields. And maybe this is the moment where we should really wrap up, and I hand back to jpiamr. So I think this was a fantastic discussion, a panel discussion. I would like to thank all the panelists. It is a fantastic reflection of jpiamr with a very different, geographies, disciplines which are coming to contribute to jpiamr. It's also a good reflection on the connections and network aspect of jpiamr and the need, underpinning the need for research and activities in that field. So again, thank you very much, and I'm handing back to Patrick.
Thank you, Till. And on behalf of the jpiamr, I would like to thank you for moderating this session, and all the panelists for very fantastic discussions and insights and comments. And also to the audience who have been watching us. And I would just like to say that this webinar is available on the JPIMR Facebook page and will be also available on the JPIMR website. And one of the things you mentioned is that we still need more data, and we hope to come back with the third webinar after the summer, sometime August, September, where hopefully maybe more publications are out and we can continue this discussion. So thank you again, and hope to see you again in real life. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you.
Bye.